Hello and welcome back to SoundBites Ultrasound. My name is Dr. Phil Pereira, and in this video module, we're going to cover an advanced application of ultrasound, that of the rush exam, which stands for Rapid Ultrasound in Shock in the Critically Ill Patient. This module will be video part 1 and will cover how the rush exam, a series of ultrasound applications, can be combined into one whole protocol for the assessment of the patient in shock. Let's begin with a clinical case that outlines the power of the rush exam. Here we have a 67-year-old male presenting via paramedics for acute shortness of breath for several hours. The medics phone ahead with the vital signs, and they have a blood pressure of 90 over palp, a heart rate of 120, and a respiratory rate of 32. They're calling ahead for a notification because the patient appears to be in severe respiratory distress. The patient has a significant past medical history, significant for COPD, congestive heart failure, and hypertension on multiple medications. He states that his baseline blood pressure runs about 160 to 170 systolic, and that he's been compliant with his blood pressure medications, making the blood pressure of 90 over palp a big change from his baseline. As the patient arrives into the emergency department, he's immediately placed into the resuscitation area, and the vital signs are reconfirmed, showing significant hypotension, as well as a low-grade fever and hypoxia. The patient is talking to you, but does appear to be in respiratory distress. On lung exam, he has diffuse expiratory wheezing and inspiratory rales at the bases, and edema is present in the lower extremities. So the question for you is how best to proceed at this point. Well, most of us would order a portable chest x-ray, an EKG, and some baseline labs. Here's the patient's chest x-ray, and it's read as no acute infiltrate, effusion, no pneumothorax. The heart size was seen as normal, and notice here there's no real evidence here for pulmonary edema, i.e. no real infiltrate or cephalization. The patient's vital signs clearly indicate an advanced type of shock, and the clinical question here is, what type of shock is this patient suffering from, and what is the best treatment option for the patient? Could he have A, distributive shock, of which sepsis would be the most common, B, cardiogenic shock, C, hypovolemic or hemorrhagic shock, or D, an obstructive type of shock, of which the three main causes, cardiac tamponade, pulmonary embolus, or tension pneumothorax, must be considered. Thus, in the resuscitation area, it's a little unclear as to which type of shock our patient is suffering from, as he has elements in his physical exam and his evaluation that overlap between the four different types of shock as detailed here. In the past, it would have been relatively easier to figure out which type of shock this patient was suffering from by placement of an invasive pulmonary artery catheter or a Swan-Ganz catheter. This was commonly done when I was training in internal medicine back in the 90s and gave an amazing amount of physiological detail with regard to the patient's state. Unfortunately, multiple studies looking at these PA catheters found an increased rate of complications and no improvement in overall morbidity or mortality of these patients. Thus, their use has drastically declined in the recent past, setting the stage for the use of non-invasive measures of shock assessment. The rush exam was initially written to fit the void for non-invasive evaluation of physiology, in this case using bedside ultrasound. The rush exam, a series of ultrasound elements that was combined into a protocol, was initially published in Emergency Medicine Clinics of North America in 2010 and then republished several more times in 2012. The rush exam was therefore written as a three-part ultrasound evaluation of the patient in shock. The first step was evaluation of the pump. Here we were looking for three main things. First of all, assessing the heart for the presence of a pericardial effusion or cardiac tamponade. Number 2, evaluating the left ventricle for contractility, and number 3, evaluating the right ventricle for strain or dilatation that could indicate a large pulmonary embolus in the correct clinical scenario. Number 2 was the evaluation of the tank or intravascular volume. The first assessment here was how full is the tank, and this was performed by evaluation of the inferior vena cava or internal jugular veins. The second part was to evaluate if the tank was leaking or compromised, and this involved elements of the extended fast exam and also lung ultrasonography, looking for the presence of a pneumothorax or ultrasonic B lines. The third part of the rush exam was the evaluation of the pipes, first looking at the arterial circuit for problems such as abdominal aortic aneurysm or thoracic aortic aneurysm, which could be the cause of the patient's shock. Second was the evaluation for the major venous circuit, mainly focusing on the legs for assessment for deep venous thrombosis. And this part would be included especially if the echo showed right ventricular strain to confirm the presence of a possible pulmonary embolus. The rush exam is therefore an easily remembered ultrasound protocol for the assessment of the patient in shock that utilizes the mnemonic of pump, tank, and pipes to incorporate many ultrasound elements into an evaluation. Here's a table that encompasses many of the major resuscitation shock protocols that have been published to date, and we see them across the top of the table. Let's look specifically at the rush pump tank pipes protocol. To the left, we can see the protocol ultrasound elements that have been combined into many of these resuscitation protocols. And we can see that the rush exam combines many of the protocols to date, starting with cardiac and IVC exam and continuing on through the fast exam, the aorta exam, lung ultrasound, and finally the DVT examination. In a series of upcoming videos, we'll go over how to use the rush exam, i.e. how to evaluate the pump, the tank, and the pipes to figure out exactly what type of shock the patient is suffering from and how best to treat the patient in the resuscitation area. And hopefully by the time we go through all these videos, this table will make a lot more sense. We'll be able to use the rush exam to figure out the specific type of shock that the patient is suffering from. Is it hypovolemic, cardiogenic, obstructive, or distributive? And we can see how the different findings within the pump, tank, and pipe categories can help us in determining this etiology for the shock. So I look forward to seeing you back as SoundBites continues and as we further explore the rush exam in the upcoming series of videos.